Hello, I'm Brent Walker from Patient Bond, and what Patient Bond is a platform for behavior change, basically through digital patient engagement. And we were given an opportunity today, thankfully, to be able to share some pretty provocative results on some work that we've been doing in reducing hospital readmissions for congestive heart failure. And we're also working in collaboration with the American Heart Association to address those initial admissions to hospitals, basically trying to prevent the progression of the disease itself. Before I get into some of those results, though, you look at the title of this presentation, Reducing Hospital Readmissions Through Psychographics and Technology. I'm guessing some of you in the audience are probably saying, psycho what? What the heck are psychographics? Well, psychographics pertain to people's values, attitudes, beliefs, lifestyles, and personality. And this is the core to intrinsic motivations. And this is the core to communication preferences. And if you can understand these insights, then you can craft messaging that can drive behavior change. And where did this all come from? A little bit of background. Prior to Patient Bond, I spent 20 years at Procter & Gamble in the healthcare division, okay, working on the pharmaceutical and the OTC products and all, and I was using psychographic segmentation to try to change both consumer and actually provider behaviors. Psychographics are relatively new to the healthcare industry, but it's commonplace with consumer products companies and retailers like Walmart, who I work really closely with on psychographics also. This is actually, psychographic segmentation is one of the secret ingredients to the success of P&G launching billion-dollar products. I think when I left P&G, there were 23 products that were generating about $1 billion, if not more, of revenue per year. And each one of these products has a psychographic model behind it. Because what it allows them to do is talk to the consumer or talk to the shopper or the patient at a very emotional level, often a subconscious or unarticulated level, to get them to drive shopper behavior and purchase behaviors. Well, as sexy as it is to market Pepto-Bismol, my partners and I ended up leaving Procter & Gamble and saying, you know what, this methodology and these consumer techniques can be very valuable and actually help the greater good. Actually go beyond just marketing some of these products to help people take their medications, follow the doctor's advice, and stay out of the hospitals. But when we left, one of the things that we noticed in the marketplace was that a lot of health education was kind of one size fits all. Basically sending the same things to everybody out there, almost as if the industry or the healthcare was treating people like walking disease states or walking health conditions, as if everybody with a cardiovascular condition thinks and acts alike. We know that's not true. Not all millennials think and act alike. Not all men and women think and act alike. Not all ethnicities think and act alike. But you have to recognize that. The other thing that we noticed too was that we've been hearing you need a lot of education. Keep throwing information out at the patients. Something's going to stick, and we're going to drive behavior change. And what I would say is education is a necessary component, but it's not sufficient. If education alone was sufficient for driving behavior change, then why would Johns Hopkins find 52 to 53% of physicians are overweight or obese? Why would UCLA find that a quarter of all LPNs smoke? These are the most health-educated people that are out there. We're not going to teach them anything new. But there's something going on behind the scenes, some intrinsic motivations that they prioritize certain behaviors over others, and it may be counterproductive to wellness. And if these people can't do the right things, how can we expect patients to be able to do the same? And that's where we get into the psychographic segmentation. It helps understand the why. Why do patients do what they do? And can we group people according to these shared characteristics for more efficient targeting and messaging? Well, in the 20 years that I was working at P&G and 5 years since we've been gone there and working into Patient Bond, we've identified 5 distinct psychographic segments. Each one is very unique in their approaches to healthcare and their motivations. Some are wellness-oriented, very proactive in taking care of themselves. Others are very reactive or maybe even disengaged in their health. Some are going to put doctors up on a pedestal or an institution and say, hey, you guys are the experts, tell me what I need to do. Whereas others are saying, doctors are just one variable among many. Guess what? I'm going to spend a lot of time on the internet trying to figure this thing out. I need options and choices. Other people need very specific directive guidance. There's 100 of these little contrasts and tensions that go into the persona of each one of these psychographic segments, and recognizing that even though two of these segments can behave the same way and appear that way within a utilization database or a claims database, the reasons why they're acting that way could be very different. And if the motivations are different, what you need to say to trigger and activate behaviors has to be very different. Now, what Dr. Peterson showed earlier today is a shout out to Sidebench. Actually, we're collaborating with Sidebench, talked about the psychographic model that's going in there. That's this model, as a matter of fact. So we're really excited to be working with other innovators in this space. Now, Patient Bond itself, again, as I said, is a platform for behavior change. What we do is we start with a population. The 5 psychographic segments actually appear in all patient populations, all subpopulations. The distribution of the 5 segments may be different, but they do appear out there. So we'll take that population and we'll segment them. This information came from big national market research studies that we did, representative of the US Census, 400 questions in all when you go through the whole thing. We're able to boil it down to 12 questions that in 1 minute we can figure out with 90% certainty which of these 5 segments you fall into. Again, using the kind of consumer methodologies of the Procter & Gamble's of the world. Another way of getting to this, we've actually got an agreement with a big national data compiler called the KBM Group. Probably more familiar with Experian, figuring out your credit scores through third-party data sources. They're just like that. But we worked with their data analysts to actually statistically project these segments onto everybody in the United States over the age of 18. It's not as predictive, but you can act against it really, really, really quickly. So once we know what psychographic segment a patient goes into, then we enact the digital patient engagement, emails, text messages, interactive voice response, building it into app software like what Sidebench offers up for this West Coast health plan that we're working with. But each one of these communications is personalized to that individual patient based on their psychographic profile. So you can say, hey, take your medicines. There's 5 ways to say that. Okay? And if you can identify which person that you're trying to target with the right message, that's marketing 101. It's what I grew up with at Procter & Gamble for all those years. But this is a systematic way of being able to do that. And each one of these communications actually has a response prompt or an embedded action that allows the patient to answer questions, surveys, do they comprehend the information, feeds back to the patient bond system, and then we can monitor what's going on, especially with readmissions, understand what the recovery process looks like. I think you saw this slide earlier today. This is actually what we called at P&G the brand building framework. If you understand the who, why, what, and how of the consumer or the patient in front of you, then you're going to be able to change their behavior. Healthcare historically does a fantastic job on the who and the what. Who is that patient? Demographics, socioeconomics, the health conditions that they have, and the what? What are their behaviors? Utilization data, claims data, it's all telling you like the labs and the prescriptions they're getting and how often they go to the doctor or the hospital. What we try to do here is through the psychographics answer the why. It gives you the consumer lens to interpret that ocean of data that everybody's been talking about over the past couple days. And if you know the why, you then know the how. What is the right combination of communication vehicles, text, email, et cetera, even snail mail. So actually hard copy mail works better for certain segments than digital too, so we have to build that into it. But we want to augment the practice of medicine and try to bring consumer insights to the marketplace. Now, I mentioned that we're doing some work on CHF readmissions. I'm going to take you through a case study here really quickly. This involves a large nonprofit hospital system who was seeing historically about 18.5% readmissions for CHF. Now, that might sound kind of high, 18.5%. In the absolute, maybe it is. But if you look at CHF readmission rates across the country, it's somewhere between 22 and 24%. So there's a huge opportunity here. It's a tough nut to crack, but this system was doing very, very well. So we want to see if we can actually lower those readmission rates. And then secondarily, make sure that we're either maintaining or improving patient satisfaction, and totally important here, don't disrupt the workflows. Make sure your greatest ally in this whole thing is the clinician, the nurses and the doctors. Make sure we're not making this a hassle for them. So we minimize that. So what we did, actually before we instituted this program, When the patients were getting discharged, the nurse would hand them a 62-page book of all this education content, said, read this. Now that we're discharging, you read this at home. And I'll let you guess which of the 5 psychographic segments are actually going to read 62 pages. None. No one, that's not what humans are going to do. If they're in an emergency situation, they're not going to try to go to page 48, paragraph B, blah, blah, blah. So what we did was we took their content, because we're not clinicians. We took their content, and this is where working with the American Heart Association is so fantastic, because you're not going to get better content, so we want to use that information. But we segmentized it. We took their education, came up with 5 versions of it based off of the patient's personalities, and made it bite-sized chunks over the 30 days. So for instance, on day 5, monitoring your weight. You gain 2 pounds, or you gain in a day 5 pounds in a week, you might be retaining fluids. That may be a precursor to readmitting. So what we do is, again, text message, email, voicemail. This isn't a pretty email. We had to blind this and take out the logos of the company and all this. It looks a lot better of this when it's getting executed, because the patients see it coming from the health system itself. But this says all the reasons why you ought to be paying attention to your weight in segment language. And included on here is this interaction, this embedded patient action response mechanism. Click here, and we're going to ask you 5 questions. In this example, typically we're asking 2 or 3. We've got to make it pretty seamless and efficient for people. But do you have shortness of breath even when you're at rest? Do you have chest pain that doesn't go away? Are you gaining weight? So they'll answer this in a dashboard. This does not remove the human element from this. I think the questions that were talked about earlier before we got up on stage about you can't remove the human element from this, dead on. The whole idea is to drive efficiencies with the human element. The dashboard, red light, yellow light, green light basically means, hey, the patient acknowledged they received the communication, nothing's going bad, I don't think they need follow-up, so they're green light. The red lights might have answered some of those questions in a way that says, oh, there's some consequences here. They're probably going to readmit. So it shows up immediately in real time on the dashboard. But it also sends text messages and emails right to the nursing unit. So they do immediate follow-up. And again, another great quote from earlier was managing the exceptions. Yeah, you can care for the population, but if you can use something efficient like this to manage the exceptions, you're going to drive efficiency with the human capital that you've got. And as you're interacting with people that might be having problems and coaching them over the phone or in person, you can capture call notes and whatnot. This whole thing's auditable and archived. The system's actually cloud-based, and it communicates with a medical record or any administrative record via just simple API calls. So it's pretty simple and straightforward. The results from doing this is actually a 5-month pilot. After 5 months, there were 315 CHF discharges in this cluster of hospitals in this overall system. Saw a 90% reduction in all-cause readmissions. Drove it from 18.5% down to under 2%. Since then, they said, okay, we're done with the pilot, let's stop and see what happens. Readmissions have started climbing again, so it's like we're going to reinitiate that one. It's too important. 62% response rate across 14 waves of psychographic communications. Historically, emails, text messages might get 5%, 7% response, maybe 10 if you're lucky. So we're actually talking to patients as people. It's resonating on a level of their priorities, their motivations, who they are and what their personality is. There are words to use and there's words to lose when talking with different segments. And then they also cautioned us, hey, this population's 65 and over. They're not going to like digital. That's a myth. Okay, 65 and over. Some, admittedly, may not like it that way. But we said, let's put in like a study afterwards, and the health system talked to the people that went through this. Of the 315, 94% said this was extremely helpful. I really liked this. This actually made the whole process a lot better. It was my safety net. It was my security to know that if I have a problem, I don't have to call you and spend all my time describing the problem. You already know what's going on, so we can immediately address it. Went over pretty well. The other thing too, to get across is we've actually been in this neighborhood working with Mass General. This has gone on for about 18 or 19 months. This shows that even outside of cardiovascular in a different disease category or health condition, this is a form of spinal surgery. Over about 18 or 19 months now, we've driven readmissions down to 1.45%. And it just got recently published in the Journal of Neurosurgery. So we've got, see me after this. I can give you copies of this if you'd like. But good reference point. I mean, this can be used across the spectrum of healthcare. Now, where this brings us today is with the AHA and looking forward. So we have been collaborating and coming up with a personalized care plan using the health motivation assessment. We talked about the Life Simple 7 earlier today. Basically, it's kind of the AHA's way of segmenting based on risk. And we figure out, okay, this is how we prioritize and set the priorities of the content that we're going to use. We run patients through the psychographic model. And if you can picture a matrix of the 7 different lifestyle issues, or exercise, non-smoking, and whatnot, and then prioritize what's going to be the most impactful, like for the willful endurer, it might be physical activity, smoking, and nutrition. That will then personalize a 12 to 52-week program to address their personal needs, prioritized to their risk, set in a way that they can actually, it resonates with them. So this is my last slide here. These are actually 3 areas that we're working with the American Heart Association today and taking that great content and segmentizing all of it. A 12-week prevention wellness program, basically for the general population to drive awareness, a 12-month prevention and management program for very specific health conditions within cardiovascular, and then the 30-day readmission. We're going to expand on that, replace the content we've been using from the hospitals with AHA great content. So we're going to market right now, and again, we're working with Sidebench on the 12-week program too. So it's going pretty well. It looks like I'm at 0 time right now, and I can see I'm about to come up with a shepherd's crook. So if you need to contact, I'm going to be here for the rest of the day. This is our contact information, and actually we're working very closely with Pat Dunn in the back too. He's been our main collaborator here, so if you have questions about this kind of work, he can answer that also. But thank you. Appreciate the time.